Good morning, everybody. It's Keith Coker. So we're going to switch into a new agenda topic here. Really important one on balancing measures that Michelle Nypaver and I will tackle. So let's reset on what a balancing measure is. This is really a critical concept within quality measurement. Balancing measures are intended to understand the unintended consequences of any quality improvement effort. So things like, are we causing harm by the work that we're doing? We have done this analysis in the past. It's been a couple years, and we've refreshed it and want to provide that information to all of you. Our intent is also to bring this to you in more of a open, on-demand way through the Tableau reporting structure. So we're working to be able to create those kind of reports for you to look at independently as well. So I'm going to walk through a couple of these before giving the mic to Michelle. So first, let's talk about head injury. So actually, before I get to the punchline, so the kind of harm that we'd be looking at here would be, say, as we ratchet up the quality improvement work, we're less likely to do a head CT on a patient with a minor head injury following the Canadian or the PCARN rules. And so the potential unintended consequence might be that we miss a case of a severe head injury. And so that's the rationale behind what we're doing here. And so what we did in the adult population instance is we looked for cases of ED visits that qualified for a minor head injury that were determined to be low risk by the Canadian clinical decision rules. And then those events where there was no CT performed, according to the rule, and those patients were discharged home. And then we looked in our registry for cases where patients returned to our emergency departments and were subsequently discovered to have a severe head injury. So the type of injury that we would ideally have identified on the first visit. We tied that to instances where the patient was then admitted or transferred because of the possibility that sometimes there's some messiness in ICD-10 diagnostic codes, and maybe we'd be picking up on injuries, say. And the punchline is we had over 24,000 instances over the last couple of years in which this occurrence happened. And only one case came back that was subsequently identified as a severe head injury, which to me is incredibly reassuring that we're not causing harm. The analogy here in children is with use of the PCARN rule. For those familiar with the rule, in this case, it identifies in particular this inner where there is some equipoise in children between doing a CT scan versus observing a child before determining they're okay. And again, similar kind of analogy. We looked for cases where there was this risk group, intermediate risk, where a CT scan was not performed and the patient was then discharged home. And then within 7 days, did they return to the emergency department with ultimately a diagnosis of a severe head injury and were admitted or transferred. Just so you have a flavor of what we mean by severe head injury, it'd be things like intracranial bleeds, skull fractures, those kinds of injuries. And again, punchline, like extremely low events. Out of a denominator of over 8,000 cases here, we had only 2 of these events in the couple years of data that we are looking at. So that should be really reassuring to all of you that as you follow the evidence here, we are reducing those low value studies without causing harm in this quality initiative. Okay, so I'm going to move on here to pulmonary embolism. So this is our balancing measure. It takes a little bit to understand what we're doing here. So let me set this up. So what we've done is identify cases where a pulmonary embolism is diagnosed. And then we look for 7 days prior to that ED visit in which the case was made, that diagnosis was made, for any preceding ED visit of any type, which, to be honest, may or may not be related to the actual final diagnosis of pulmonary embolism. They could be totally coincidental and unrelated. But I think conceptually what we're trying to get at is, was there a missed opportunity to diagnose that pulmonary embolism earlier at that prior visit? And perhaps because of some of our quality work, where we're getting more evidence-based in how we do the diagnostic tree to make that diagnosis, are we missing cases? And so what we're looking for here is changes in trend. I don't think we know what the true balancing measure rate is. You can see there's a tremendous amount of fluctuation month to month in the frequency of these events.
Keith, we have a couple questions
sure.
about head injury. So first, for the adult minor head injury balancing measure, the question is whether or not we're looking at cases where the patient was negative according to the Canadian CT head rule, but was scanned anyways, secondary to physician discretion, and ended up with a significant head injury.
It's a good question, and I think it's a good point too. We have not done that analysis yet, but I understand why that could also be a complementary balancing measure. So we'll take that back. I think what we're looking for is to provide sort of a big lens on any potential harm or adverse events as a result of following this quality improvement work. So great point. We'll consider it for sure. So let's get back to the pulmonary embolism discussion. I think I was right at the point of wrapping up here. I think the bottom line take from me is, there's a lot of variability in the trend in this line. I don't think we know what sort of the sort of true rate should be, but it's more about the change in the trend over time. And within the confidence intervals, I don't think we can say that we are pushing harm here. So this is certainly something we'll continue to keep an eye on as we move forward, again, as a balancing measure here. So the final measure that I'm going to talk about is low risk chest pain. What we're balancing, the measure that we're balancing here is harm from adverse cardiac events. There's a definition here that we're drawing on that's out in the literature. It's been around for actually a few decades, something called major adverse cardiac events, or MACE. So these would be events like myocardial infarction or heart attack, unstable angina, those kind of things. And we're looking at a 30-day window after the period of time when a patient was determined to be low risk and discharged according to the HERE plus T criteria that we have adopted, and how often we're seeing returns to our emergency departments with these adverse cardiac events. Again, we don't know what the correct rate is. I think we all have to expect that things are not going to be perfect. I think most of us would probably accept a rate that's under 1% here. And using that standard, we are certainly at a rate that is far less than that. So out of a total population of over 13,000 cases, we've only seen 13 since we've introduced this quality initiative. So again, I think we're demonstrating safety here in our efforts to improve. Okay, so I'm going to pass things over to Michelle, who's going to talk about the final initiative here.
Thanks, Keith. Similarly, we're going to take a look at the balancing measure from a pediatric perspective. And remember, we worked very hard on the pediatric chest X-ray utilization measure back in 2019. And from evidence in the national literature, as well as the pediatric committee, we thought One balancing measure we were particularly interested in is why we typically do a chest x-ray in the first place for these conditions. And it's often because we're worried about a pneumonia. Certainly not all, but the bulk of that was pneumonia. So we've been watching the obvious return of children who come back to the ED with a final diagnosis or code for a pneumonia. And in this case, again, we're happy to see that literally very few children do return with that diagnosis, 133 out of 63,000, which is less than, 0.25%. So we're very happy to see that. And similarly, for those kids, remember, asthma is a supplementary measure, and we're looking at returns for those children within 72 hours who are then admitted to the ICU or transferred because they're very ill. And again, these are small numbers, and again, these are 11 out of 4,000. So literally, we are doing very well in these measures in terms of not having significant collateral damage. Certainly, we want to watch these carefully, but we haven't done this in a couple of years, and I'm very happy to see that we're really not having an impact on untoward outcomes. So terrific news.